get this class started. So I know there's still a few that aren't here yet, but I want to make sure that we don't lose too much time. Welcome again. This is Nursing 130, which is Fundamentals of Nursing Med Surg 1. Most of you I saw yesterday. Just an FYI, because I know you guys have a group chat for your classmates. You do have some extra classmates now that have joined us, some students who were online and that kind of thing. So please reach out to them. You can find them under the people part of. Of Canvas, and you can reach out to them and add them in. Um, Hi, Kristen. Um, so we're gonna get started. For those y'all pretty much know me, I think I'm Professor Trainer. Been a nurse for almost 17 years, teaching the last couple. Um, So I'm not sure there's anything new I can really tell you guys. And when we get back in the classroom, we're going to do a whole introduction thing because, well, then I'll actually be able to put faces to everything. So I'm going to start. Actually, I have the canvas up for fundamentals. So I am going to share my screen so we can kind of go over these things while we're here. So as you see, Nursing 130, we're in the home. So you've got your recent announcements and things like that, instructor information, course overview. Books. This is a big one a lot of you guys have asked me about. So I'm going to tell you, you need, if you like hard copies, great. If you want to use the electronic, that's fine too. So one big thing, Davis's Comprehensive Handbook of Lab and Diagnostic Tests. This one is very important for you guys. I will tell you this electronic version is not easy to navigate at all. I don't particularly like the navigation with it, but you can find this has all your labs. By diagnostic, we're talking about CAT scans, radiology, any other diagnostic type procedures you might do. Nursing implication, things you need to know. For instance, someone's having a CAT scan with contrast and they're diabetic. They should not take metformin for 48 hours prior to the test and about 48 hours afterwards. So those are some of the things that you'll find under nursing implications. Mosby's Nursing Drug Reference, always a great book to have. The problem with this one is they update it so often. So you buy a copy of it and then it's obsolete in a year or two. But for the most part, everything will be about the same. Davis's Drug Guide, not sure why that's in there. Haven't used it. More familiar with Mosby's. I like Mosby's format better. Fundamentals of Nursing, this is your main textbook that we will be using. And it has everything that you'll be using. For their manual of IV therapeutics, not getting into that one really in this class. Med Surg Nursing Assessment, definitely going to use that at least for Med Surg 2, 3, and 4. And the last chapter that we reviewed in Fundamentals will be from this book. Nursing Diagnosis Handbook. I'm going to dive into this in a few weeks when we start doing care planning and the nursing process. This handbook is going to save your life, guys. I do not want you to copy and paste from it. However, you'll be able to do a care plan so easily if you use this book. It is going to be your godsend. Physical examination and health assessment. This is one of the books I still have, the Med Surg one and Fundamentals. I still have my copies. Physical exam and health assessment. I don't really use it a whole lot, but it is a good one to have. Then you also have your clinical nursing skills and techniques down here at the bottom. So it's actually a step-by-step walk you through each procedure. And then you also have the study guide for that. Well, this is the study guide for fundamentals. And then you have the study guide for Med Surg. Guys, these are very, very good. It will help you tremendously if you use these. Week lecture 1, these are listed as lecture, not week. For those who may not be aware yet, because of the current status of things, I have had to front load your lectures. What does that mean? Well, normally you would have Tuesday lecture and Thursday morning you would have skills lab. But since we cannot be on the campus and we cannot be together, we've had to move the skills lab in the hope that we'll be able to bring you back to campus. And it may be in small groups. But Dean Arias did ask me to go back a little ways. In fact, actually, Dean Arias and Professor Foster are supposed to be here sometime soon. So hopefully they'll pop in.
We are here, Professor Trainer.
There they are. Okay, awesome. Good morning.
Good morning.
So I will let you guys go ahead and take the floor.
Hey, how's everybody doing? Welcome back. First week, exciting. I hope you guys enjoyed your time off and excited to get started with the semester. So, do any of them have audio working, Professor Trainer, or are they just using the chat?
They've just been using the chat. I asked them to mute just because of all the background noise.
Okay, perfect. So Professor Foster and I wanted to come in and welcome you guys to the new term. We wanted to give you guys a couple updates. So we do not have a definitive date of when we'll return back to campus. And I know Professor Trainer was just talking about the lecture, so front-loading lecture. So when we return back to campus, we can get your skills lab hours that are required for the course completed. So as of right now, we're going to maintain on the online platform until further notice. As soon as we have a date, we will let all of you know as soon as we know. The other thing regarding clinical hours, so we have not received dates from the clinical sites when we can return back onto site. So Professor Foster will let you know when you guys will have your virtual simulation days. We're trying to keep it on the days that you would originally have clinical. So you'll be receiving that information. And the virtual simulation, if you guys aren't familiar with, it's really interesting. You learn a lot. So Professor Foster will be in communication with you guys regarding how that's going to work. And I believe, Professor Foster, they don't start until week 6.
Correct. They start June 3rd. Will be their first day.
Okay. So you guys will receive an email regarding your groups and how the virtual simulation is going to be run. So all that information will be sent out to you guys. The other thing I wanted to let you know is I'm going to be going on maternity leave starting next Monday. So Friday this week is my last day, and Professor Foster is going to be stepping in for me while I'm out. So your first person you're going to go to is going to be your instructor, so Professor Trainer. Miss Julie Williamson, who's our administrative assistant, you can also email her, and then Professor Foster would be the next person to contact. So I wanted to see if any of you had any questions regarding anything for either one of us.
Silence.
No questions? Okay.
PMI has extended their off-campus lockdown till May 18th. Is it safe to presume we will most likely follow suit?
I don't know. We can only go by what Carrington is doing. So I know the other schools kind of have their own agenda. So again, as soon as we know a date, we will let you guys know as well. Even when we do get approval to go back to campus, we may need to do it in smaller groups as well. We're always following the law and regulations for Arizona.
And as far as the clinical question, we're in touch with the Arizona State Board, and all of the schools across the nation are in the same boat as far as how many simulation hours they are going to accept along with their clinical hours. So right now, before this even started, the State Board of Nursing was accepting 50% of simulations for clinicals. So you guys are in good shape, even if we have to do a lot of sims this semester. it would still be less than 50% by the time we get back to the hospitals. But yes, we will keep you informed, and we're up on that and following it closely with the state board.
Any other questions you guys have for us?
Professor Foster, I think Adriana was concerned about like all the requirements, the immunizations, TB testing, CPR.
Oh, okay. We're not, as soon as we're going to get back to the campus before we get back to the hospital. So that it's not the same deadline for completing all of your requirements for clinicals. Thank you, Deidre. Now that I read it the way you say it. But so there's leadway. We know it's hard to go and get everything. So the deadlines are flexible. So if you can get as much done as you can get done by the time we get back to campus, then the list is smaller.
Mm-hmm. Well, I'm going to put my email in the chat here. So you guys thank you. Thank you, Veronica. You guys are more than welcome to email me if you have any questions that come up this week. Also, you can let Professor Trainer know. And then I'm going to put Professor Foster's email in here as well. Thank you, Adriana. So I hope you guys have a great rest of your day. Great first week of class, and let us know if there's anything we can do to help support you guys. All right. Thank you, Professor Trainer. Take care.
Thank you both.
Thank you.
Bye.
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 Okay, guys, I know so much is up in the air and it's kind of crazy. So we're all just going to kind of muddle through. So back to where we're going. Okay, fundamentals. So what I was just saying is lecture is front loaded. So today is lecture 1. And tomorrow and Thursday morning will be lecture number 2. So the first 8 weeks are going to be strictly lecture, and that is just so we can try and get you guys skills labs done, hopefully within the time frame. So when I did the syllabus, these are the modules, but when I did the syllabus, I tried to make it as easy as a breakdown. But please feel free to let me know if you have any problems, questions, concerns. So here's your lecture week 1, lecture 2. In lecture 3, which would be next Tuesday, we'll talk about your first paper, and also your quiz is next Tuesday. One thing I did is almost all the test quizzes are on Tuesdays. There's one at the end that's on a Thursday, and all your assignments like a paper, presentations, those things are due on Thursdays. The other thing that's going to be odd is that your midterm is actually literally still midterm. So the midterm is in week 8, and that's the time when we're actually going to be, as you can see, it's lecture 15. There's 16 lectures. So you're going to be that's going to be kind of weird, and you're going to be ahead of the game. But, we'll work through it. And then so lecture 16, so that's the final lecture. This is the Thursday lecture where you actually have a quiz. Then we'll start skills lab in week 9, as you can see, week 9. And we've got all your checkoffs here. And then we come down to the end here. Oh, week 14. I don't know why that came. So week 14 and 15, you guys will have simulations. And then the week 16, you'll have your final exam. And then you'll also have maybe more simulation, and we'll just review all the skills. So want to go through that really quick with you. I will get to the syllabus in just a second. Excuse me. The other thing you may see, you're going to see, week 2, Kaplan number 1. What's Kaplan? Well, Kaplan is a online resource that we use to help prep you for NCLEX. So each of these, there's 10 of them due. There were 3 points. Let me unshare this because I don't want you guys seeing all my stuff when I pop up my things. You should have received emails for Kaplan. So you can log in. You need to get logged in and make sure it's working. If you didn't receive an email about it, please let me know. I believe some of you have already told me that you have. So yes, skills lab are skills that you're going to learn. So there's certain checkoffs for different skills. We have head to toe assessment, vital signs, um, what else is there? Foley catheter insertion, trach care, tracheostomy care. So we have you work through it, and then you then we will check you off to make sure that you are safe to do so. Once you are checked off on a skill, you are then able to perform the skill in your clinicals. So the skills you cannot do until you perform them, except for medication administration. You cannot give any medications this term at all. So. Okay. Okay, so this is Kaplan. You can see the website, captest.com. You guys will need to start your account. Okay. This is the student view, for lack of a better term. So this is what you will see once you get all started. And you're going to do access resources. So, yes, thank you. Okay, so you see here you have several choices. You have focused review tests, overall performance, integrated tests, NCLEX channel has a lot of great information in the content library. So your Kaplan assignments are the focused review tests. So things you can do, you can create your own if you want to. Sorry, guys. You can create your own, and then you have these that are available. Most of the students choose, oh my Lord. Sorry, guys. Most students choose one of these to do. So for instance, we're going to do a section on fluid and electrolytes. So maybe when we're getting to that one, you're going to want to do fluid and electrolyte A. So you would click on that and it will actually, you can start. You need to have a 63% or better to actually be considered pass. If you don't get a 63 or better, or even if you do, what I would like you guys to do is what's called remediation. So you would actually go back and review the entire thing. It goes through each question and gives you the rationale for each answer. So you may have answers that you got correctly, but you're still going to review them. Maybe you do know the rationale, but maybe you're like, I don't know, it just seemed like the best answer. So it will actually give you the rationale so to help you with a better understanding of that. Okay. Sorry, I stopped sharing for a minute to get out and get back in again. So that is your Kaplan. And what you need to do for that one. So syllabus. Need to add a thing. So I did post the most recently edited syllabus for you guys. So we'll just go through this very quickly. Just waiting for it to come up. Sorry. Where is... Oop. Technology is wonderful when it works. So I'm just going to share my desktop right now because that's what you're seeing. All right, so fundamentals of nursing syllabus. Again, same information you guys have seen before. 16 and a half years, I didn't update that. It'll be 17. Been in Tucson for 11 years. Married. I have an adult daughter who lives at home, stepson who's married and lives in Utah, and another stepdaughter who's 18 and getting married in July. So more about the learning outcomes, course requirements. You know you must pass with 75% or above. Okay, nitty gritty here. So week 1, you see week 1, there's 2 different dates. So this is Tuesday, this is Thursday. The topics that we're going to be going over and the chapters for each one. So we've got the orientation, the lecture, and the lecture. Week 2, you have your first Kaplan due, and quiz 1 is not in week. Oh yeah, quiz 1 will be there. So yes, you'll have quiz 1. I know you're going to have back-to-back quizzes, and I'm sorry, guys. It's just weird. You've got your paper that we'll be doing. Lecture 6 we'll go over. Then you have your Thursday. And then week 3, you have exam 1, Kaplan number 2. So when it says, I changed these to say lecture 6 as opposed to week 6, because as you can see, week 6 is actually in week 3. So I tried to make this as easy as possible for you guys. If there's any confusion about it, please let me know. So we're in week 5. You see here on the 28th of May, you have your group presentations, which are due in lecture 12. I will have you guys set up into groups, probably groups of 4. There's 29 of you. So we'll have 6 groups of 4 and 1 of 5, I believe. Here is week 6. I did mark that it's the first week of clinicals, simulation, whatever, more quiz, presentations. And yes, I assume you'll be doing the presentations online. Continuing presentations will definitely need to. Then you'll have a case study that's going to be assigned, your midterms, more Kaplans. This is the end of lecture right here is the midterm and the last lecture on that Thursday. So week 9 is when we go into skills labs. Hopefully we'll be able to do that. Kaplans are also still continue to be due. I did not front load the Kaplans. So, and you have your checkoff. So actually in week 3, well, what would be, so yes, second week. So week 9 on Thursday lab, you'll learn head to toe assessment. The actual checkoff for that is not until, well, week 4. So it'll be lab 4. So some of those are like that where you're going to start learning them and then you'll do them later. Foley catheter is another one where you don't get checked off the actual week you learn it. Then we have week 15, sorry. Subject matter exam, Kaplan. So that is, remember when we were first on the Kaplan page, it said, when I was on your different selections, it said focused assessment and integrated. Well, the subject matter exam is an integrated test. So I will schedule that and then you guys will take it during class time. There is no studying for the SME or the subject matter exam. There is nothing you can do. Taking the Kaplans, reviewing those, that's what you can do in order to do well on the subject matter exam. And then you see here more simulation. We'll have to see what we're going to do. And then we end with our final exam and the last day of review any skills. Again, everything must be in the APA format. Academic integrity. So to help with academic integrity during testing, just a reminder, everybody needs to have a device that will allow me to view you through a webcam. If you do not have a device that allows you to do that, then I will need you to use your phone. The State Board of Nursing released a statement that they are very concerned about dishonesty or, quite frankly, cheating on the tests. So they're asking that all schools please use some sort of video monitoring system. What that means for you guys is that Respondus will be the monitoring system. And what it will do is it will watch you. You'll have to prove you are who you are. It's going to watch where your eyes track. It's going to, you're going to may have to show your desk before you get started, all those things, just to keep down the concern about cheating. Grading, you have 4 quizzes, 2 regular exams, the midterm and the final. The final is worth 250 points. It is 100 questions. Subject matter exam, so that final Kaplan, the integrated, is 50 points. Erickson and your Maslow's paper, the QSIN presentation, your case study, your Kaplan, and then skills lab and clinical is pass-fail. On it, actually, Natalie, I'm not sure. I think when you go into the test, it'll automatically activate for you. Dr. Karp is actually doing a test run this week with her students, so I will know more about exactly how the Respondus monitoring works after that, and we'll probably do a practice run at some point, hopefully before Monday. Methods evaluation, 75% minimum. Methods of instruction, attendance information. I do need you to be here. It's better for you. You're going to do better. Right now, it's hard to determine attendance because we're online, because you can be signed in and then you could go do whatever. It's not going to help you. So, testing policy, Carrington testing policy. I reserve the right to adapt or change the syllabus at any time. Late assignment, again, 5% deduction, no more than 5 days. So that is basically your breakdown of the syllabus. Sorry, guys, it's trash day for me, so the trash truck just went by. Any questions for me about the actual syllabus itself? Any classes? Okay, so I know most of you were on here like really early. So normally I'd probably go another half an hour before we took a break. So the Kaplan test, Mercedes, so when you do your Kaplans, you'll choose which focus test you do, and then it's a percent. So if I look at it, I can see how much time you took to remediate. I can see your score. So say if you got a 93% and you took maybe 10 minutes remediating, I'd say that's probably the full amount. However, if you got a 57% and only did 2 minutes of remediation, yeah, you probably didn't remediate all the questions you missed. So I'm not going to give you a full 3 points. The final subject matter exam is graded. There is a, the tests are normed. So after 300 students take the test nationwide, they can figure out an average and we can then put a percent on it based on that. So there is a completion component. You need to complete your Kaplans to get any points, but I also need to see your score and I also need to see that you remediate. So if you get 100% and you don't remediate, That's pretty obvious. If you don't get 100% and don't remediate, then you didn't really do. Nathan, that wasn't an email you should have received from Kaplan to be able to open your account. So if you didn't receive an email from Kaplan, please let me know. Liera, so you actually can choose. You guys, there's no assigned one until the integrated test at the end. So I do recommend, that, a lot of the ones, there's math ones. So if you're struggling with math and dosage calculations, you will also have a Kaplan subject matter exam in pharmacology. Okay, Nathan, I'll make a note of that and let our rep know. So you'll also be doing this in pharmacology, so you can feel free to do some dosage calculation ones. There's fundamentals A, B, and I think there's even C. I will make sure the list got sent. Also make sure you check your spam. Jolynn, I prefer that you guys not take the same test. Because then you're only focusing on one subject matter. And I want you guys to get a broad one. So there's a lot out there. There's cardiology, there's the fluid and electrolyte. So maybe for the next Kaplan you want for the next week, say on the week that we talk about fluid and electrolyte balance, maybe you want to do that Kaplan and test how well you understood the lecture. So I would say that's a recommendation that I would have. And that would help you further focus on what you understand and don't understand. Okay. So I will double check and make sure that the roster went out to the Kaplan people. Some of you, if you have attended another school that uses Kaplan, I think PMI and PIMA both do, you may already have a Kaplan account, but that may not mean you're active yet. So I ran into that last term with one of my students. So I will reach out and make sure that the roster got sent so you guys can get logged in. But that's why there's not a Kaplan due kind of right away. And I'll let you all know. Okay, so since we, like I said, a lot of you were on here very, very early this morning, like before even 8 o'clock, which I appreciate. I figured we'd just take a quick little, 10-minute break. So be back about a quarter after 9 or 9:15, a little bit, 9:17, and we'll get started with the lecture. Okay? So be back here at 9:15. my gosh, you guys are so awesome. Look at you all helping like that. Yes, Jessica, that would be true. If we don't get you in time to do it, then I'll probably make it due Thursday. Oh, look at you. Okay. So, Kappa 1 is due next Tuesday. However, if we have to change that because not everybody's able to get in, that's okay. I may leave it just due next Tuesday, and then those of you who aren't in and it takes a little longer, no worries. I just sent an email to Dean Arias to make sure that the roster was sent so that you all have access to it. Oh, yes. Miss Julie is the most awesome. We couldn't do things without her. She literally sent me an email this morning reminding me I forgot to post attendance for yesterday because, I'm out of my groove here. And I was like, oh, good gravy. But no, she's super awesome. Super, super awesome. And last Thursday was administrative assistant day. So we all got together and bought her a really nice edible arrangement. The chocolate covered strawberries, she says, were done in 5 minutes. And by the next afternoon, everything was gone. So I'm glad she enjoyed that so much. Up, yay! So I will ask those of you who still have checked and haven't. I have most of you written down. So we're going to go ahead and get started again. There are a couple students who are still missing that I haven't seen comment, and they're not showing up on the list of people within the chat. If anyone notices that there's anyone missing, if you know, can get in touch with them or know who they are, hey, that'd be great. Otherwise, I'll get in touch with them via email here in a little bit. So, Kaplan, I know some of you aren't in there yet. Some of you are. So I will work on that. That's on my agenda for today after class. Does anyone have any other questions or anything that's coming up? Because don't feel stupid about asking a question. The only stupid question is the one that you don't ask. You all will get a study guide for every quiz. I'll post that here this afternoon after class. Actually, after I eat lunch first, because that'll be my first priority after class. I did post the study guide for the quiz for math. I can't actually access your accounts, Courtney. On my end of the faculty end, I can look up each student individually. I can look up by date. I can look up by test. So what I usually do, I can look by cohort. Oh, thanks, Shelb. I appreciate that. Miss your face. So what I will do is I just look it up. So for instance, I can go in and I can look up Courtney Benson and it will show me what tests you have taken. And it will also show me what your score was, what date you took it, and how much time you spent in remediation. So I'll be able to track that way. These are really easy point guys with the Kaplan. I had a few last term that like missed 1 or 2 or 3, and those 3 points can be huge. So I really, they're easy. So please make sure you get them done and get them in by a timely manner, So if you have a Kaplan due, it's due by the beginning of that class. So make sure you do it within that week time frame. Okay. All right, so I am going to back to share my screen. All right, am I sharing my screen? Yes. Okay, fundamentals of nursing. Some funnies for you guys. The one on the left about a nurse, it must be getting old because all these new nurses Hey, I'm back. No, no ending class early. You don't get that lucky, Tim. So anyways, sorry guys. Somehow, some reason, some way, whoops. my connection just completely took a dump on me. So we will try this again. I appreciate all your patience. Hi, I'm back. Oh my gosh, that was just not good. So let me get back to the PowerPoint here. My apologies, guys. I do not know what happened there. Yeah, probably. Okay. So we're going to back to sharing my screen. Fundamentals, okay. And then this other one, only a nursing student gets excited about their first stethoscope. This is about the time where we'd all be going through our backpacks that you guys are going to get. Because you will have a stethoscope. I'm trying to remember what all, there's all the kits that you need for all the skills. So those are things you'll get. Yes, I know you did, Tim. It's a Carrington one. It's got the Carrington on it, even. It's embroidered. Fun, right? Anyway, so some of you might get blue, some might get black. It's very exciting. Anyway, so that is the one that you will use for your skills lab, and you'll need to bring it with you, and it will have all your good stuff in it. And again, normally we do introductions. I usually do a cheers and a fears. We may look at that towards the end here. And of course, always funny, who says nursing is stressful? 39 and I feel great. No, not beers. Standards and scope of practice. So you guys are right. You guys are held to a standard of practice. The standards of practice are what every nursing, anyone who practices nursing, what you must follow. The standard of practice for nursing is what we call ADPI. Although they did add an O in there. So it stands for A is for assessment, D is for diagnosis, P is for planning, I is for implementation, and E is evaluation. You guys will learn this, know this, and love this. This is everything. You also have the ANA standards, which ANA is the American Nursing Association. And they set the standards for nursing, and then the state boards allow them. So the standards of professional performance, you've got your ethics, that you practice ethically, your education, that you have a certain level of education and competency, that you use evidence-based practice and research, that you contribute to the quality of nursing, that you can communicate effectively, that you demonstrate leadership, that you also are able to collaborate with others. Professional practice evaluation, so you evaluate your own practice in relation to the standards. Excuse me, guys. Resources, that you use appropriate resources, and then environmental health, so you help keep the environment as healthy as possible. The scope of your practice is defined by each state board. So you will actually, the Arizona State Board of Nursing, or AZSBN, is who sets your scope, what things you can do, things you cannot do. There is a link right there if you wanted to go to their website, not right now, and talk about and look up exactly what your scope of practice will be. So in nursing, you start as a novice, and there's Benner's stages from novice to expert. So novice is a beginning nursing student or a grad nurse with no previous level of experience. An advanced beginner has a level of experience. It may be observational, and you're able to identify principles of nursing, but maybe you don't feel really competent. A competent nurse is one who's been nursing in the same clinical position. So this means, say you're working in a specialty like maternal child, and you've been in that position for 2 to 3 years, you would be a competent nurse. Now, if you've been in maternal child and you move to, say, oncology, you're going to go back to at least advanced beginner, because you're going to be learning something all over again. Proficiency, you're going to have more than 2 to 3 years experience in the same clinical position. And you're going to be focusing on managing care as opposed to skills. And then an expert is one who has a diverse experience and an intuitive grasp of clinical problems. You're able to zero in and focus, and you can identify both patient-centered problems and problems related to the system, more than anyone who's a novice nurse will do. So I'll be honest, guys, I don't think I've ever moved to, well, I have some aspects of expert. I won't profess to be an expert, but I guess I am an expert. But I am definitely proficient. So there are going to be times where you're going to be like, I feel really good. I'm an expert in this. And then other times where you're like, I feel like a complete novice. And that is totally normal. So your professional responsibilities and your roles. Autonomy is an essential element of professional nursing. You have to be autonomous. No one's going to be there to tell you guys what you're doing or how you're doing. You need to be able to be independent and initiate independent interventions without having to have a physician's order. There are times where you can do things and you don't need an order for it. The accountability, that means you're the one who's responsible, both professionally and legally, for the type of care and the quality of care. The levels, Benner's levels from novice to expert are kind of your own feeling. They're kind of a guideline, 2 to 3 years experience, you're an advanced beginner, more than 2 to 3 years, you're proficient. But it also depends on if you're staying in the same clinical area or moving on to somewhere else. So accountability doesn't just mean you're accountable for yourself, guys. You are accountable to anyone you delegate to. So a lot of you guys are techs or MAs. When you become a nurse, you are accountable for what the tech does. If you tell your tech to do something and it's outside their scope, that's on you. It's also on the tech if they do something that's outside of their scope. But if they say to you, I'm not comfortable doing that, and you tell them to do it anyway, and there's a bad outcome, that is on you, as are your own actions. The caregiver in you will help the patient maintain and regain health. They'll manage their disease. You'll help manage disease and symptoms. And the most important is getting the patient to the maximum level of function and independence. So nursing isn't just helping to cure the disease or treating the symptoms. Sometimes there's nothing you can do, much you can do as a nurse about those. That's up to the physician. But you can help the patient become more independent. So an intervention you might do is to have the patient ambulate in the hallway 3 times a day. You will also be providing healing, and you're not just a caregiver for the patients, but you're also helping their families. You're an advocate. You're there to help protect the patient's legal and human rights, and help them in asserting those rights. Informed consent's a big example of this. A lot of times the doctors will be like, oh, we're going to do this procedure, blah, 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 and they walk out of the room. And the patient really has no clue what's happening. You're the advocate that needs to go to the physician and go, look, I'm not having this patient sign this informed consent. It's not appropriate. You didn't teach them. You need to come back and talk to them. They're not comfortable. Educator, this is huge. You're going to spend a lot of time teaching your patients and their family members. You're going to explain concepts and facts about health, describe the reason for routine care activities. Well, why do I need that? Well, let me explain to you why. You're going to demonstrate procedures. If a patient needs to learn how to straight cath themselves, you're going to teach them. You're going to reinforce any learning and any behaviors. And evaluate the patient's progress in learning. Are they learning what you want them to? You may have a formal learning, you may have informal learning, and you may have planned or unplanned. As a communicator, you need to have effective communication, not just with, okay. Okay. So, communicator, it's central to your nurse patient relationship. You need to be able to communicate well to your patient so they can learn things, and your patient needs to feel comfortable communicating with you. This is essential for all nursing roles and activities you do. You have to be effective at communication. And then the manager coordinates the activities of members of the nursing staff, um, organizing and being a leader. Career development. You guys are on the journey of 1,000 miles, and this is your first, well, this is not your first step. Your first step was enrolling and starting school. Providing care, you can provide care in any number of settings. It can be in the patient's home, in the hospital, in an outpatient clinic. Advanced practice registered nurse. This is the most independently functioning nurse that you could have. You have advanced education in pathophysiology, pharmacology, and physical assessment. You have your clinical nurse specialist, which is an expert in a specialized area. So maybe gerontology, so a certain population or pediatrics, disease in a certain setting, acute care nurse practitioner in the type of care or type of problems. You also have your nurse practitioners, family nurse practitioners, acute care nurse practitioners, different, they have subspecialties. Your certified nurse midwife that provides independent care for women during a normal pregnancy, labor, and delivery, and care for the newborn directly afterwards. This also includes gynecological services. However, like a family nurse practitioner can also provide some gynecological services, but can't do the pregnancy part. You have your certified registered nurse anesthetist. They have to have 1 year critical care or ER experience before you can even apply to this program. And you provide a CRNA would provide surgical anesthesia under the guidance of an anesthesiologist. Now, state scopes vary by for advanced practice registered nurses. For instance, as the state of Arizona, I'm a licensed family nurse practitioner. I do not need to to prescribe medications. And if I have a DEA number, you can prescribe control medications also. However, in other states, it's not the same. Some states require the nurse practitioner to work like a physician's assistant underneath a physician and with additional collaboration in place. You have your educator. This is nurse educator. You could be a school nurse, staff development. So you could be a nurse educator in the hospital, educating staff, patient education, a diabetes nurse educator. You do need to have clinical experience. Nurse administrators, they manage patient care and delivery in specific nursing services within an agency. I don't know where the slide went, Jolynn. I still have it up. What's wrong with my shark? I like my shark. All right, can you guys see it now? Ah, okay. Not sure what happened. It fell asleep. I don't know. Uh, okay. Okay, so nurse administrator, kind of self-explanatory, and then nursing research, where you study evidence-based practice, do research to improve care, and also help define. Seriously, Shelb, you should have figured that out by now. And research to extend and define the scope of practice. So, what about the history here? So, that first lady there on the left, that is our illustrious Florence Nightingale, basically the mother of nursing. She wrote a book published in 1860 called Notes on Nursing, What It Is and What It Is Not. She also organized the first program for training nurses, and she was the first practicing epidemiologist. So she practiced during the Crimean War, and there was a lot of fatalities and mortality during that. So she had a mortality rate of 42.7%. No, the other side, Folashad. She had a mortality rate of 42.7%. So in 6 months, that number went down to 2.2%. What she did is organized and improved quality and sanitation. Okay. So just by using hand washing, keeping things clean and sanitary, she brought down the mortality rate by 40.5%. And then we have the Civil War to the 20th century. The middle person there, the middle lady there is Clara Barton. She tended to soldiers on the battlefield during the Civil War. This is where the growth of nursing happened. The first ambulance service was created. And Mother Bickerdike actually was the one who she walked abandoned battlefields looking for wounded. So on the right hand side, the African American lady is Miss Mary Mahoney. She was the first professionally trained African American nurse. And nursing actually within communities did not expand until 1893. Now we enter into the 20th century, where we get nursing moves more towards science and research. Nursing education got actually moved into universities. Nursing practice expanded. And by the 1920s, nursing specialization occurred. Now here we are, 21st century. We're still revising nursing practice and curriculum, and we're adding advances in technology and informatics. So that is the story of nursing in a nutshell. So some of the more contemporary influences, things that are influencing us today. Self-care. You can't take care of others if you're not taking care of yourself. Nurses are horrible about self-care. It's very, 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 very important, you guys, that you take time for yourself. You need to make sure you care for yourself. If you don't, you can get compassion fatigue, which is a state of burnout, and you get secondary traumatic stress. It can happen without warning, and it can be from giving high levels of energy and compassion over a prolonged period. Burnout happens when the demands of your career outweigh your resources. Sometimes you'll see lateral violence, so nurse on nurse conflict. I think the best example of that is current practicing nurses eating their young. So by that I mean you student nurses or the new grad nurses come out and the older nurses are not there for you. Snide remarks, nonverbal expressions, that is considered lateral violence. It is not acceptable. One of the things I've always thought about, I love having student nurses when I was practicing. I love teaching because I want you all to be exceptional nurses. And I'm not doing you any favors if I'm treating you like crap. So, the Affordable Care Act, that's how healthcare is paid for and delivered. If you, some of you may think of it or know of it as Obamacare, it is actually not. parts of the Affordable Care Act were actually instituted prior to Obama being president. Those of you, a lot of you will know about HIPAA, the Health Insurance Privacy and Portability Act. That is actually the first step of the Affordable Care Act. So this provides greater emphasis on health promotion, disease prevention, and illness management. The idea will be more nursing would be community-based, getting the best care for the least amount of cost. But healthcare costs continue to rise, especially in over 65. We need more healthcare resources. And population is still shifting from rural to urban. And there are more people living with chronic long-term illnesses because life expectancy has changed. You also have unemployed, underemployed, and those in low-paying jobs. They're underserved. Mental illness, homelessness, all of that contributes to being underserved. The number of patients who are going to need palliative care, which is not the same as hospice. Palliative care is comfort, but it's not end of life, is increasing. And the cost of providing home-based care is also increasing. So there are a lot of issues and influences on how nursing is currently. Trends, evidence-based practice, always been super uber important. The way you practice needs to be based on the evidence. The evidence needs to show that what you're doing is beneficial. We need the research to show that. You're going to hear a lot about evidence-based practice, and there's a whole part of a lecture on one. Then you have QSIN, that's quality and safety, education and nursing. There are 6 competencies: patient-centered care, teamwork and collaboration, evidence-based practice, quality improvement and safety, and informatics. If you look at those, you'll know a lot of that actually relates to the standards of professional performance. Then we have emerging technologies, so EMR systems, genomics or genetics, which are helping us determine people's risk factors, the public perception of nursing. The nurses have always, well, not always, generally, mostly have been the number one most trusted profession in a survey of people. So the public perceives nurses as being honest. There was only one time in recent history when nurses were not ranked number 1. Nurses were ranked number 3 or 4, and that was after 9/11. After September 11th, police and fire actually rose to number 1 and number 2 spots. And then the impact of nursing on politics and health policy. The American Nursing Association has its lobby. There are other groups that have its lobby. I'm a member of the American Association of Nurse Practitioners. They have a lobby, and they are working with politicians to try and increase and make nursing a better field for us. A lot of you will know there's a lot going on with patient load or patient acuities. And that's something that's been in the works for a long time, and we're still working, striving towards to make sure we maintain safe nursing practices. So you have your professional education, nursing practice, and professional organizations. So for an RN, generally you need an associate or a bachelor's degree. There is still diploma programs out there, but very few. You will all need to pass the NCLEX, which is the National Nursing Licensure Exam. It is a national exam, but it does not give you a national license, which is kind of silly. Some states do have compacts. Arizona is one of them. So I am allowed to practice in any other state that nurses that is in a compact. So you also have graduate, where you have your master's, which is what I have, or your doctorate. If you get your doctorate degree or doctorate of nurse practice, DNP, you are not allowed to be called doctor. Physicians don't like that, so they have kind of put the nix on that. Veronica, you can actually just Google nursing compact states and it will give you the list. So a DSN or DNS is research based, a PhD is theory based, and then the DNP is for advanced practice. You'll have continuing education and in-services. They can be formal. You do have a required number of hours of continuing education or CEUs that you need to maintain your license. In Arizona, it's 30 hours. You need 30 hours of CEUs for every 2 years. You may have in-services within your own institution. As we talked about, the ANA sets the nursing standards of practice. State boards oversee your scope. Each state has their own scope. All state boards in the United States require you pass the NCLEX, which assures that you have a minimum knowledge base. You can also get certification if you want a specialized. There's many national organizations with many types of certifications. And then you also have your professional organizations. So the American Nursing Association is one. They deal with the issues of concern of those in practice, lobby, expand roles, and set standards. I also put here on this slide, you'll see the National Student Nursing Association. That is something that you guys definitely could look at joining, and something to help you lobby for better education and better things going on. So, patient safety and quality. So, basic needs. Anyone remember Maslow's? Who remembers Maslow? I know some of you do. So we talked about CUSIN. That was developed to meet preparing you with the knowledge, skills, and attitudes. Knowledge, skills, and attitudes to continuously improve quality and safety of care. So CUSIN safety competency minimizes the risk of harm to patients and providers through both system effectiveness and individual performance. So you see here, basic needs, oxygen, nutrition, temperature, Maslow's hierarchy, right, guys? Physical hazards, motor vehicle accidents, poison. Now, poison, I'm not just talking about chemicals that you shouldn't take. Medications can be considered poison too. And yesterday we talked about overdosing on medications. That's considered poison. We have falls, fires, and disasters, which are physical hazards. Transmission of pathogens. A pathogen is any microorganism that is capable of producing an illness. So a lot of times we'll use immunization to reduce and prevent transmission of disease. If you guys haven't learned about transmission yet, you haven't been watching the news. And then we talk about pollution, a harmful chemical or waste material discharged into water, soil, or the air. So now I have a quick little video for you guys all about. Seriously? Hang on, guys. Oh, pause. Whoops. Whoops. Oh, lovely technical difficulties. Yep, my sound is on. Anyone else? Did you hear it? I know Veronica says she didn't. Hmm. This is the cool part of my lecture. Okay, yeah, so that was the safety dance. I'm really bummed because I love that one. I think it's so cute. Anyways, try to kind of break things up a little bit. But so we've been going for about an hour now. So I'm going to give you guys I'm glad gee, thanks, Angelica. You make me feel so much better. I was born in the 70s. Just kidding. Okay. So what I'm gonna do, you guys, let's take another 10-minute break. Well, a little bit over 10 minutes. Be back here at 10:15. And we'll keep plugging away. So get yourself something to drink, stretch your legs so you don't get blood clots. Use the restroom so you don't get a urinary tract infection. See all about patient safety. No, I'm just kidding. Anyways, so get something to eat if you need to. Anything you need to do, go ahead and be back again at 10:15. Tim, that is way too much TMI. Okay, guys. Oh, my screen share was on. You guys all saw what I was doing. So let's go back to from current slide. Get started again. Oh, not that. All right, factors that influence patient safety. So you have certain risks at developmental stages, infants, toddlers, preschoolers. You're thinking about things like lead poisoning, injuries. Remember, toddlers are top heavy. Their heads are big, so they have a tendency to fall. Fire, and then just accidents. School age children, you're looking at stranger danger, also accidents and head injuries. They're learning how to ride a bike, and they're not wearing helmets. Adolescents, they get into risk-taking behaviors. Adults, you have your lifestyle habits, smoking, drinking, doing drugs, accidents, or any illness. Older adults have things like falls, of course, accidents, and then some wander, especially those with dementia. Then you have individual risk factors like your lifestyle, again, drinking, drugs, stress, um, impaired mobility can lead to falls or psychiatric issues. For instance, feelings of isolation, sensory or communication impairment, they may not able to perceive danger or express the need for help. And we're not just talking about being like blind or deaf. Some people may have an illness that makes them not be able to feel sensations. So they don't know when the stove is hot and they burn themselves. Lack of safety awareness. You want to keep your kids away from medications, wear a helmet when bicycling. Check expiration on food. If they have a lack of smell or a lack of taste, they may not realize that food is expired. Then you have your risks in the healthcare agency. Falls, of course, is always a risk. Patient inherent accidents are accidents that are other than falls, which the patient is a primary reason. So something that's self-inflicted, injection or ingestion of foreign substances, that kind of thing. Procedure related, that would be medication or fluid errors. They are caused by healthcare providers, improper application of external devices, or improper performance of procedures. So putting in dressing changes, inserting a Foley catheter, IV catheter. And then equipment related is just what it says, related to malfunction, disrepair, or misuse of equipment, or it can be related to an electrical hazard. So we have assessment. You get your nursing history, and that is where you ask the patient about their medications. We'll go more into assessment a little bit later. So history, health history, medication history, allergies, all those things. You're going to assess your patient for risk for falls, their mobility. Are they able to move? Elimination, urinary and bowel habits. If they're incontinent, that may cause issues for safety. Any high risk medications they might be on, antihypertensive medications, pain medications, and also their cognitive status. And then you also have medical errors due to overwork, fatigue, and using two identifiers anytime you're giving a medication or doing a procedure. So now up here on the slide, you should see that you see the pictures of the two different rooms. Both of these rooms have risks for falls in them. Now, most of you might look at the bottom picture and go, well, yeah, totally. I mean, there's crap everywhere. So, and then you're looking at the second one going, really? What's there to fall over? Well, number one, there's a throw rug. That's a tripping hazard. A lot of patients can trip and fall, especially the elderly. Yep, the dog, you're absolutely right, Veronica. Pets, they get in the way, they go through your feet. Those who have cats know cats like to be around your feet. Even that little dog statue could be a fall hazard if there isn't enough lighting. So even in the spaces that you think might be the most safest, you really need to look to to see what is actually going on in the environment. Implementation. They've got to be, it's important for a patient to be in the safe environment. So, we're looking at interventions that might be linked to developmental, also environmental, basic needs. So, interventions, infants, back to sleep. So teaching parents that the children need to sleep on their back. That's health promotion. Immunizations, not having pillows or bumper pads or large stuffed toys in the crib. I mean, all these are for like interventions for toddlers. You get into the the preschoolers, teaching them to swim, but also making sure they're supervised. Teaching them how to cross streets and walk in a parking lot. Stay away from strangers. School age children, how to use equipment safely, how to bicycle safely, including helmets and rules of the road. If you are, if All right. Yes, Natalie. Absolutely. Can you guys hear me? Okay. I'm not sure. I'm thinking, Adriana, that might be on your end. Adolescents, driver education classes, informing them about the use of drugs and alcohol, mentoring, safe internet use. With adults, you're going to want to guide them to make lifestyle modifications. Older adults, they're going to have to compensate for the physiology of aging. Make sure they have their basic needs, and making sure that if they don't, they're referred to the right resources. Preventative measures, making sure there's adequate lighting and security, removing any obstacles, using a life alert, smoke detectors, carbon monoxide detectors, and educating on medications. Fall prevention, a lot of places they'll use yellow, so the yellow socks and wristbands. Other nursing interventions, having the patient sit on the side of the bed before they actually rise, using lower beds. Restraints, you want to exhaust everything else first. Restraint is the last resort. Physical restraints or any manual or physical or mechanical device, including all four side rails, that prevents mobility or reduces the ability of a patient to move. Chemical restraints are anxiolytic medications and sedatives. Those are more for managing behavior, and they are not a standard treatment. Alternatives you can use to restraints are frequent observation, social interaction, frequent reorientation, regular exercise, and introducing familiar or meaningful stimuli. If you have your side rails up ×2, that is not considered a restraint. Fire, you want to use the mnemonic RACE, RACE. Rescue or remove all patients in immediate danger. Activate the alarm. Confine the fire by closing all doors. And then extinguish if you can. If you are using a fire extinguisher, you're going to use the mnemonic called PASS, PASS. Pull the pin. Aim at the base of the fire. Squeeze the trigger and then sweep from side to side. Electrical hazards, you want to remove any equipment that's unsafe and report any unsafe hazards. Seizure precautions, you're also going to make sure you use the special pads. Even when I take my dog to the vet, though I have a dog that has seizures, not grand mal, but she does have seizure disorder, they put a special collar on her that has a bell that rings if she starts having a seizure. Well, if she starts moving her during her seizure. Radiation, there's little badges for people who work in high radiation areas that measure your exposure. And then, of course, there's always natural disasters, which there's no control, but we can do the best to. And that's why we have a lot of disaster drills in healthcare. Infection prevention and control. Infection is an invasion of a susceptible host by a pathogen or microorganism that results in disease. You may have colonization, which is the presence and growth of microorganisms within a host, but there's no tissue invasion or damage. So people who have MRSA or methicillin-resistant Staph aureus may be colonized, but not actively infected. A communicable disease is a disease that can be transmitted directly from one person to another. And a person may be symptomatic where they're showing signs of the disease or asymptomatic where they don't show any signs, but they have the disease. And that's kind of where COVID-19 is such an issue because we don't really have, you have people who are not symptomatic, but they are infectious. So again, infectious agents are any microorganisms, virus, bacteria, protozoa. Things that you can do is help keep your immune system up. When we talk about the virulence or severity or how strong of a microorganism infectious agent is, we're talking about the ability of it to produce disease. The reservoir is a place where the microorganisms survive, multiply, and await transfer to another host. Things you can do to prevent this is keep things cool and dry. Make sure you're fully cooking your food. A lot of them need food. A lot of infectious agents will need food. They need oxygen, although sometimes you have aerobic and anaerobic, which don't need oxygen. They need moisture. Temperature, the ideal temp for most human pathogens is 68 to 109 degrees. pH, most organisms prefer 5.0 to 7.0. And a lack of light. So they thrive in the dark. Portal of exit is just that. It's the way they exit the reservoir, whether it's through blood, skin, mucous membranes. Excuse me. If you use standard precautions and follow isolation precautions, you should be safe. So things from skin and mucous membranes, we're talking about, pus, purulent drainage, respiratory tract, your sneeze or your cough, your urinary tract, GI tract, reproductive tract, and blood. Mode of transmission is how the disease is transmitted. Wash your hands, wear PPE. That helps block the mode of transmission. Portal of entry, same routes as exit. So how it exits is how it's going to enter. So if you use aseptic technique, good hygiene, you're going to be, you should be relatively safe. And then you also have to have a susceptible host, and that depends on your degree of resistance. Sorry, guys. Infectious process. Okay. A localized infection, you're going to notice local symptoms like pain, tenderness, warmth, and redness at the site. Systemic is an infection that infects your entire body and can become fatal. Now, you have some normal bacteria floras. They don't cause an infection when they're in their usual area and in their usual amounts. Now, if they have an overgrowth, that can cause an infection. A lot of times, though, broad-spectrum antibiotics will get rid of both the abnormal and normal organisms, so you may end up with an issue there. Your body defenses, they're physiologically suited to the structure and function, like cilia within the lungs. Inflammation is a cellular response of body tissue to injury, infection, or irritation. So you have a vascular response where it's going to deliver fluid and blood products and nutrients to the area, to the cells, to cause them to have the cells to be there, and also to have the energy and needs the cells have to fight off the infection. They neutralize and eliminate pathogens or dead necrotic tissues. Signs and symptoms you're going to see for an inflammatory response: swelling, redness, heat, pain, or tenderness. And you may even have some loss of function. That is localized. Now, systemic signs and symptoms are the fever, increased white blood cells, malaise or just feeling bleh, anorexia, nausea, vomiting, lymph node enlargement, or organ failure. Exudates are fluid and cells that are discharged from cells or blood vessels. When you have the rapid vascular and cellular response, you're going to have rapid vasodilation. So the blood vessels are going to open. That increases blood flow, which is what causes the increased redness and warmth at the site of inflammation. You'll also notice your swelling there. Chemical mediators get released to increase the fluid, protein, and cells can enter into the interstitial or tissue spaces. That accumulation of fluid in the tissues is called edema. This causes an increased pressure on nerve endings, which can end with a temporary loss of function. White blood cells arrive. They go through the blood vessels into the tissue. Phagocytosis, destruction, and absorption of bacteria occurs. White blood cell count, an increase in white blood cell count is leukocytosis. So increased white blood cell is leukocytosis. That increases the amount of circulating white blood cells. If fever occurs because of a release of pyrogens from the bacterial cells, which causes an increase in the set point of your hypothalamus. Again, the inflammatory exudate is the accumulation of fluid, dead tissue cells, and white blood cells. You can have serous fluid that is clear like blood plasma, sanguinous, which contains red blood cells, purulent, which has the white blood cells and the bacteria. Usually these are all cleared through your lymphatic system, and damaged cells will be replaced. New cells mature gradually until the same structural characteristics and appearance as the previous cells occurs. If there's chronic inflammation, the tissue defects will fill in with granulation tissue that forms the scar. Now, your scar and surrounding tissues will not be as strong as the normal regular tissue. So that tissue repair, while it provides functioning tissue, is not going to be as strong as the previous tissue that was there. So we have healthcare associated infections, and you have so exogenous infections, which occur from outside the individual. Endogenous, which are part of your normal flora that becomes altered. Like I said, when you take an antibiotic and your normal flora decreases or increases. Iatrogenic infections are caused by invasive or diagnostic or therapeutic procedures, bronchoscopy, treatment with broad spectrum antibiotics. Healthcare associated infections, or HAIs, result from the delivery of health services in a facility. So factors that influence infection prevention: age. Your susceptibility levels will change throughout your life. An immature or defined immune system, so definitely infants with their immature immune system. And your immune response will decline the older you get. Looking at nutritional status, a decrease in protein and other nutrients decreases body defenses. Stress also decreases the immune system. And then some disease processes. So you have diseases that affect the immune system. Chronic diseases due to can cause uh, debilitation. So assessment. Your defense mechanisms are your intact skin, weak cough, etc. Patient susceptibility, we just discussed. Some medication therapies can compromise your immunity, so you want to look at their medication history. Also look at the clinical appearance. How does your patient look? Do a physical assessment. Do they look sick? Do they look well? What's going on? Here we have some lab tests that you would do to screen for an infection. So you've got your white blood cell count. An increase shows an acute infection. Decrease can happen in viral or overwhelming infection. So if someone's septic, erythrocyte sedimentation rate, also known as a sed rate, it elevates when there's inflammation. Iron level can be decreased in chronic infection. Cultures of the urine and blood will show you the microorganism. Differentials, different types of white blood cells. So the neutrophils, so they're increased in pus-forming infection and decreasing in an overwhelming bacterial infection. Lymphocytes increase in chronic bacterial and viral infection, decreases in sepsis. Monocytes, eosinophils, and then basophils. So things we want to do, we want to promote health. The idea is to strengthen your host defenses. You want them to have a proper diet. For instance, if a patient has a wound, they're going to need a diet that's higher in protein to help things, tissue build up. You want to collaborate with the dietitians, the patient, and the family. Always, always, always collaborate with the patient. They don't buy into your plan of care, they're not going to follow the instructions. You want to make sure with hygiene that we keep the body clean and avoid spreading microorganisms. So, for instance, wiping or cleaning the perineum, making sure that they have good perineal care after bowel movement and urination. Immunizations, getting your boosters is recommended in your immunizations. Some people will be dead set against it, and the best you can do is educate them to the ability and then leave it at that. Physical exercise will increase your lung capacity, circulation, give you more energy, increase endurance. So that will, and also boost your immune system. And acute care, you're going to collect specimens from body fluids and drainage for testing. So you want to make sure you're using PPE and also make sure you're following appropriate hygiene practices. Medical asepsis. Asepsis is the absence of pathogenic organisms. By using aseptic techniques, those are practices and procedures that reduce the risk of infection. So, medical breaks in the chain of infection lead to using medical asepsis, breaks that chain of infection. So, you use it for all patients all the time. Okay. So we're talking hand hygiene, whether it's hand washing or using a hand sanitizer, barrier techniques, gloves, gowns, masks, and routine environmental cleaning. Increased use of disposable, so there's less awareness of cleaning and disinfecting, which can lead to issues because you're not in that habit. Cleaning is when you remove organic material or inorganic material from objects and surfaces. You're going to use water, a detergent or disinfectant, and then proper mechanical scrubbing. So, for instance, hand washing, guys, the temperature of the water and the amount of soap does not matter. What matters with hand washing is the amount of friction used. Okay. That's what you need is the amount of friction. More friction, cleaner hands. Disinfection is a process that eliminates many or all microorganisms, with the exception of bacterial spores. So you have two types of disinfection. You have disinfection of surfaces, and then high-level disinfection, which is required for some patient care items like endoscopes or bronchoscopes. Well, they're inserted into the patient body, and you don't want to be transferring from one to the other. Sterilization does eliminate or destroy all forms of microbial life, including spores. So spores you're going to see in Clostridium difficile or C. diff. That one has spores. Sterilization involves using steam, dry heat, hydrogen peroxide plasma, or ethylene oxide. So, on page 456, you'll see box 29-8 that talks about categories for sterilization, disinfection, and cleaning. We talk about critical items like surgical instruments or any catheters, semi-critical, so respiratory and anesthesia equipment, scopes, and then non-critical items that are bedpan, blood pressure cuffs, bed rails, linens, etc. So a lot of things that are used now are controlled emptying your Foley bags. That helps limit infection. Using antiseptic wipes on IV ports. Cough etiquette. Cover your nose and mouth. Use a tissue and dispose of them, then wash your hands. Wear a mask. Cough into your elbow. You want one personal set of care items for each patient, so you're not sharing as much as possible. Make sure you're cleaning your stethoscope between each patient. When you have to handle bodily fluids, be very, very careful and never put clean or soiled even linens on the floor. Put them in the appropriate dirty linen receptacle. Standard precautions. Use these with all patients, period. End of story. Hand hygiene before, after, and between direct contact. Hand hygiene after contact with blood, body fluids, mucous membranes, non-intact skin, secretions, excretions, wound dressings. With inanimate surfaces or articles in a patient room, immediately after gloves are removed. Wash your hands when they're visibly soiled or contaminated. When they're not visibly soiled, you can use an alcohol-based hand sanitizer. If your hands are visibly soiled, you must use soap and water. If you come in contact with spores, Clostridium difficile, you must wash your hands. Hand sanitizer does not work. No artificial fingernails or extenders if you have direct contact. That is part of our dress code anyway. Wear gloves when you're touching anything or touching contaminated surfaces is likely. Remove and perform hand hygiene directly after. So, honestly, guys, whenever I touch a patient, I wear my gloves. That's the end of story. That way, if I come into contact with anything that I can't actually see, I'm safe. Wear PPE when you may have contact with blood or body fluids. So, mask, gown. So private room isn't really necessary unless the patient's hygiene is unacceptable. Secretions that aren't contained, excretions, wound drainage, or in certain isolation. Discard all contaminated sharps and needles in a puncture-resistant container. Respiratory hygiene. Have patients cover their nose and mouth when coughing, using tissues, coughing into their elbow, that kind of thing. So the videos probably aren't going to work for you guys, which really bums me out. So what I'd like to do is have you guys make sure you go through and watch these little videos on the PowerPoints. The PowerPoints are in the Canvas in the modules under the lectures, and they're also in the files for this class. This one's my favorite. It's all about how to wash your hands appropriately. Whoops. Okay. Isolation and PPE. So we have different types of isolations. You have airborne precautions. That's droplet nuclei smaller than 5 microns. They need a private room. It needs to be negative pressure. You must wear a mask or a respiratory protection device. N95 respirators typically used. Airborne precautions, we're talking about tuberculosis, chicken pox, measles are all considered under airborne. Okay. Also, currently COVID-19, they're using both airborne and droplet precautions. People, so it's very important to keep this in mind. N95 respirators, generally, you have to be fit for them, because they need to make sure that you have a good seal and that you're going to be safe. Droplets are anything greater than 5 microns, also being within 3 feet of the patient. You're going to use those precautions. They may need a private room, or you can cohort them together, meaning patients with the same infection. A mask or respirator is required depending on the condition. So we're talking about some like streptococcal pharyngitis, mycoplasma pneumonia, pneumonia or scarlet fever, pertussis, mumps, the pneumonic plague, and again, COVID-19. Contact is direct or indirect patient or environment contact. Private room or cohort, again, patients must have the same infection. Gloves and gowns. Okay. So we're talking about MRSA, C. diff, VRE, scabies, RSV in children or immunocompromised adults. Those are contact precautions. So protective equipment is used in patients who have immune compromise. They must have a private room. It must have positive airflow with 12 or more exchanges an hour and HEPA filtration. If the patient is leaving the room, they must wear a mask. Okay. Patients can leave rooms for patient procedures or therapy if infectious material is contained or covered, or they gown and their hands are cleaned. Psychological implications of isolation and PPE. Loneliness, disrupted social relationships, increased depression, body images changes because they think they're unclean, lack of sensory stimulation. A lot of people don't want to visit patients in isolation because they have to put all that stuff on and it's such a pain in the butt and blah, 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 blah. But you need to encourage that. You need to encourage family to come and see the patient, make sure they're instructed on appropriate use. Environment. You need to make sure there is a card outside the room listing their precaution. The area immediately outside needs to contain hand hygiene and PPE supplies, a bag for soiled linens, and also dedicated use of stethoscopes, sphygmomanometers, and thermometers, so we're not sharing. PPE, gowns, it can be gowns, prevent soiling your clothes or protect contact with infectious material. Masks provide you with respiratory protection. You can have a full face, which does the eyes, nose, and mouth. When you anticipate splashing or with airborne or droplet. Eye protection would be goggles or glasses, and then gloves, of course, prevent transmission via direct or indirect contact. Do not ever walk out into the hallway with gloves on. If you're in a patient room and you're leaving the room, take your gloves off before you leave the room. If you walk out in the hallway, your gloves are assumed to be dirty, even if you literally just put them on and forgot something. I do not ever want to see any one of you walking out in the hallway with gloves on. If you go in the room, put gloves on and go, oh, darn, I forgot. Gloves come off, walk out of the room, clean your hands, go do what you need, and then come back. Specimen collection, you're going to find that on page 465. In box 2913, hand hygiene, applying gloves, cleaning the site. So with wounds, you actually want to clean the wound site with like some normal saline before you get the specimen, because you want to get all that old icky stuff out of the way and make sure you're really getting the true stuff. That one, Jolynn, that's an interesting one. Because technically, hopefully the outside of the trash bag isn't contaminated. And I can truly see why you would want to do that. I'll be honest, I've done that too. If there's particularly like if you have a C. diff patient or someone who's been having diarrhea or something like that, and there may accidentally be some contamination on the outside. And I would actually say in that instance, yes. But I don't want you walking out of the hall just to that. Taking the trash and the linens out, I totally don't blame you for wearing gloves. So, blood usually collected by a lab tech. Stool specimen, clean gloves. Urine specimen, again, clean gloves. Trash and linen. Bagging helps prevent exposure and contamination of environment. Do not double bag. Transferring patients. Before transferring patients in wheelchairs or stretchers, make sure they have a clean gown to use as a robe. If they're on airborne precautions, they must wear the mask. Make sure that the personnel in the area you're transporting to are aware of the isolation precaution. So if they're going down to radiology, then they need to make sure radiology is aware. Use an extra layer of sheets to cover the stretcher or the seat of the wheelchair. And then afterwards, make sure you're cleaning with a germicide. I did put this here for you guys on COVID-19. It's current CDC recommendations. It's the link. If you want to keep in on that, you can certainly click on it. It's the infection control recommendations on how to keep clean. Let's see if I can get it to share my screen with you while it does this. Yeah, okay. Interim infection, so below are changes as of April 13th. So address symptomatic and pre-symptomatic, implement source control for everyone entering a healthcare facility, regardless of symptoms. Cloth face coverings are not considered PPE because the capability is unknown. Face masks should be reserved for healthcare providers. Visitors and patients' face cloth covering may be appropriate. If they have one, a face mask may be used for source control if supplies are available. Actively screen everyone for fever and symptoms. Community transmission intensifies. Healthcare facilities should consider foregoing contact tracing exposures just because it's too much. So there's additional stuff here that you guys can see. Surgical asepsis. This is sterile technique, okay, guys? It prevents contaminating an open wound or the body. It also isolates the operative area from unsterile and maintains a sterile field for surgery. Surgical asepsis or sterile technique is also what you will use to insert a Foley catheter. You need to make sure that you assess the patient's understanding, assess any needs prior to doing the technique, and educate them prior to starting sterile technique. That prevents the patient by telling the patient what you're going to do and how you're going to do it. That will help prevent them from breaking that sterile field and also make sure they're comfortable. So when you're intentionally perforating a patient's skin like an IV cath, that's when you're going to use sterile technique. When the integrity of the skin is broken, trauma, surgical incision, or burns, and also during any other invasive procedures like urinary catheter or surgical instruments. So, some of the principles. Sterile object plus sterile is sterile. Okay? So, a sterile object remains sterile only when it's touched by another sterile object. If you put sterile gloves on and you touch a sterile catheter, that catheter is still sterile. Okay? If only sterile objects should be placed on a sterile field. If you have a sterile field and you put a clean object or a dirty object, that field is no longer sterile. If the sterile object or the sterile field is out of your range of vision or it's below your waist, it is contaminated. It is no longer sterile. A sterile object or field can become contaminated by prolonged air exposure to air. And if the sterile surface becomes wet, it is now contaminated. Fluid flows in direction of gravity. And the edges of a sterile field or container are considered to be contaminated. What do I mean? So about an inch around the sterile field, that is considered contaminated. Avoid activities that create air currents. So when you open it, hold the sterile field as close as possible. Never ever turn your back on a sterile field. Okay. If you have a sterile item and you touch it with a clean item, it's not sterile, but it's clean, that sterile item is contaminated. If you touch a sterile item to a contaminated area, it's contaminated. If you question whether or not it is sterile, like there's a tear or break in the covering, it is contaminated. Okay. So what you're going to do when you're doing a sterile procedure, assemble all the equipment you need and have extra supplies. So if you're inserting a Foley, you've got your cath kit and take an extra one with you. Discard an object if it becomes contaminated. Wear a surgical mask and eyewear without a cap for any sterile procedure on a general nursing unit. For sterile surgical procedures, you put a cap, then the mask, then the eyewear. Never use a sterile item if the packaging looks opened or soiled or shows evidence it's been wet. You may use the wrapper from the sterile package to create the sterile field, the inner part only. When we get into Foley catheters, I will show you that. When opening, use your dominant hand. Excuse me. That's what happens when my throat gets. Give me a second, guys. Sorry. When you're opening a sterile package, use your dominant hand to open it and the non-dominant to hold the item. Sterile field is an area that's free of microorganisms and prepared to receive sterile items inside. Sterile items. Bottles that are sterile contain sterile solutions. Those bottles are contaminated on the outside, but sterile on the inside. So if you open it and you have the cap, you either hold the cap or place it inside down on a sterile field. So the inside of the cap is technically sterile. If you put that on a sterile field, you're keeping it sterile. The outer edge of the cap is not sterile. You want to make sure you don't splash because, again, if it becomes wet, it's not sterile. You'll pour a couple milliliters into a disposable cup or a waste bin. That cleans the lip of the container, and then you will get the sterile fluid that you need out. If you are scrubbing into a surgical scrub, that's surgical hand asepsis. You're going to wash fingertips all the way to your elbows. Open gloving is done on nursing units. Closed gloving is done after you put your gown on. So sterile gloves, you need to make sure you're doing the right size. Yes, Veronica, it is. So if you cross over the top of the sterile field, you just contaminated it. So it's very, very, very important that you be aware of your sterile field and where it is at all times. With sterile gloves, you want to make sure you do the correct size glove. You don't want them too tight. You don't want them too loose. Putting on a gown allows the nurse to handle sterile objects after. So you want to put the gown on after you put your mask, your cap, and do your hand washing. Exposure issues. They're not as frequent nowadays due to safety devices on needles. So you always want to use a sharps container, but do not force it. If it's full, change it. Okay? And please don't put your fingers inside the sharps container, Tim. Just kidding. Do not bend or break needles. Do not remove a needle. Do not recap. Okay, there's going to be caveats to that, but in this world, we're going to say do not recap a needle. If you have an exposure, if you get a contaminated needle stick, notify your charge nurse immediately. Okay. You will notify your charge nurse. They'll send you down to the emergency room. They will ask the patient if the patient's okay with being tested. Consent for that test varies by state. Some states you don't need patient consent. If the patient consents, they'll test the patient, but you're still waiting for test results. So a lot of times what a employer will do, they will just sorry guys, distracted. They will start treating you prophylactically. Okay. Oh, hey, look. We're all done with this lecture. And we still got an hour to go. Hour and a half. Oof. How did that go so fast? All right. So unsharing again. Oh, we'll figure it out, Natalie. I've never gone that fast before. It was weird. So, definitely could work on self-study. What I think we'll do now, though, because I try to go about an hour or so, and then give you guys a break because it's especially hard to sit still and listen to me, going on and on. So I think what we'll do, we'll just go ahead and take another little break. Oh, one thing I want to let you guys know. I cannot allow you guys to record class. I will be recording it for you. But I cannot allow you guys to record. So it'll be strictly just me recording, and then Dr. Karp is going to assist me with setting up a YouTube channel so that I can it has to do with Teams and the way Teams works, and it allows too many access to things. So I forgot. I meant to tell you guys at the very beginning of class, and I apologize. I've been recording this one myself. But yeah. So no recording. If you have recorded, please delete it. But I will make sure you guys have access to the lectures through YouTube. Okay. So correct, Angelica. No recording on Teams only. Yes, that's fine. You're welcome. Sorry, I was just getting a message from Professor Foster. She had gotten a notification that someone had started recording, and I said, "Oh, I'm recording." So I've been recording since I started lecture. All right. Actually, I think I'll. Not a problem, Jillian. I want to make sure I give you guys everything that you could possibly can use. All right, so let's go ahead and take another break. So, as soon as possible, Jessica, I'm going to get them up as soon as I can. I know you guys use these a lot, so I will work on that right away. Veronica, you're generous. It's not that great, but it's great. So right now, let's just take a break. We'll take a little bit longer break. Be back at 20 after 11. And we will just meet back here, and then maybe we'll start working on the study guide for the quiz. That sounds like a good place to go. So yeah, so I'll be back here at 11:20. Okay. Okay. Are we all back? Hopefully. So one thing that I usually do with class that I didn't do, stop recording because it's not pertinent.